Talking about valuation versus validation, as the previous talk was, what do you think is the tension between the two, and how do you sort of balance, getting investor input, driving hype versus actually having a product that is doing real, really good things in healthcare?
I think, we touched on this a little bit when we were talking before, but I think one thing that you can do, and is becoming increasingly possible to do, is to approach venture capital that is actually well educated in the relevant domain. There's a lot of general venture capital out there who are sector agnostic, and they do want to invest in healthcare, because if you look at the objective sort of economic metrics, you've got profit margins typically of 20, 30, sometimes higher %. So they're attracted to the sector, but because they're not sector experts or domain experts, then I think they're more susceptible to the kind of hype that we touched upon a little earlier. Whereas if you get people that have maybe built a med tech company themselves, or focus on investing in that sector and have seen companies go from inception to maturity, then I think you have a much more sensible conversation and can achieve that funding without having to sort of sell your soul, as it were.
How do you think we could integrate this potentially into the electronic patient record, etc.?
Well, I think I would agree with Letitia that I think computer vision and speech recognition and natural language programming on top of that have an enormous amount to contribute. As a clinician, I would say the pains that I really would have paid somebody out of my own pocket to get rid of were mainly centered around things like EHRs and the difficulty and pain of using an EHR as a practicing clinician. And I think what's happening in computer vision and speech recognition and other things in other areas and sectors is illustrative. So let's take computer vision. If you look at two other areas where computer vision is having a huge impact, one would be the construction industry. So in construction industry, it's being used essentially for scene understanding. So you have multiple cameras around a construction site, and they're monitoring what's happening and what's taking place. And it's useful because you can do things like basically project manage much more efficiently. The other sector I would cite is security, where computer vision is having a huge impact. And essentially, it's performing the same function. It's about scene understanding. It's about understanding whether or not a person is an intruder, whether or not their behavior is kind of loitering-ish, or it's, so these kind of... So computer vision has enormous potential in the field of scene understanding. And so when we start to look at things like a busy ward or even a doctor's sort of private office where he or she might be seeing a patient, then I think you can sort of marry up the pain I had with EHR and the possibilities of scene understanding. Now, in medicine, the bar is a lot higher than it is for security or for the construction industry, so there definitely are more hurdles to overcome in terms of reliability. But I think that area has the potential to solve some of these, the fundamental problems in clinical practice. EHRs have been fantastic, but they've actually slowed down doctors and nurses because they now spend something like 20 to 30% of their time creating EHRs instead of seeing patients. So yeah, I think there's a lot to offer.
How about the guidelines around GDPR, et cetera, around this sort of non-written data?
I would say, I think, as far as sort of cameras on the ward and stuff are concerned, obviously we have to sort of have sensible data protection regulations around how patient data is captured, stored, and used and stuff. But I would say that medicine is fundamentally invasive. The reason doctors make such good murderers is because people trust them. And you will answer a doctor, I really think that's true. You will answer questions that a doctor asks you, frankly and straightforwardly, that nobody else on the planet could, in the same way that nobody else could ask you. So I think medicine is fundamentally invasive, but it's fundamentally invasive for a good reason, and there's a quid pro quo. I think we still have to demonstrate the quid pro quo to patients that if you allow these systems to operate on wards and even in your home, then you will get a great benefit, and we will take every precaution to preserve your data and your privacy. But we have to, so I think that's where we should focus on providing the quid pro quo, the payoff for this invasion.
And moving on a little bit, you're both working in and around the NHS, and I was wondering what your views are on the attitudes and perceptions of people within the NHS about disruptive technology such as yours.
Yeah, well, I don't want to become impolite, but I think we've got a long way to go. I mean, one of the reasons I left the NHS was that I tried to do a number of entrepreneurial sort of things in the NHS. Like, I tried to get the size of our clinical email inbox, the amount of storage that we had, increased. And I couldn't, because it was pathetic. It was like 70 emails, and we were supposed to be doing all our clinical work. It essentially constituted an electronic health record of our sort of daily business and our clinical care. I tried to get it increased so maybe you could store, like, I don't know, 500 emails or something. Or even just, I asked them, could you even match Gmail's free quota, which was like, I think, 15 gigs at that time. And I got no decent response. So I put up a petition, which many people signed, including many of the professors and consultants at UCL. And what happened in the end is I got a letter from management citing clauses in my contract saying that I was bringing UCLH into disrepute and that my contract would be terminated if I didn't take down the petition. And so I did. But that for me was, that was very, very frustrating, and I think, spoke volumes to me. I think we can get there, but boy, is it going to be an uphill struggle.